Welcome to the 2021 OHDSI Symposium. My name is George Hripcsak. I'm Director of the OHDSI Coordinating Center at Columbia University and Professor and Chair of the Department of Biomedical Informatics there and at New York Presbyterian Hospital. And today I'm going to give you the state of the community. Now, several of you opted for the OHDSI surprise this year, and that surprise is going to help me give you the state of the community. Let me open my surprise. Here we have it, our journey, a wonderful exposition on the OHDSI community, where it's been and where it's going. Our journey was produced by Craig Saxon with help by Patrick Ryan and the whole OHDSI community. And it tells us all about OHDSI, where we started, what we've done, where we've been, and where we're going. And I'm going to use this as you can page through as I go through my state of the community and kind of give you a verbal background to the book. Before I begin, I want to say thanks to our sponsors for the symposium, ITTM, Janssen, The Hive, Cleveland Institute for Comp Bio, Odysseus, Bayer, and we want to also thank the FDA for their generous support of the OHDSI Symposium through the FDA Scientific Conference Grant Program. As you know, all our symposia are free, whether they're in person or virtual, and we very much thank the support we've gotten over the years from our sponsors. The Collaborator Showcase is where we show all the new things happening in OHDSI, and that's a peer-reviewed forum. Very important for us to maintain our rigor and also to help advance our junior faculty careers, but it's a lot of work to create a peer-reviewed endeavor. So thank you very much for the Scientific Review Committee shown here, who put in many hours reviewing all the excellent submissions. And I look very much forward to the Collaborator Showcase later on today. I define OHDSI as a special group of people. You know, we like to think kind of as if OHDSI was started in the apocryphal garage. Shown in the upper left there is Steve Jobs' garage where he started Apple. We didn't actually start in a garage, but shown on lower left, we did start as a group of people in various venues. There's a beach from Shelter Island, also Nantucket, some forests in Connecticut, some places at work, and some homes where we came together as a group to create OHDSI. Now, the picture in the middle upper is CERN research, physics research, which is $1 billion funded research, which pulls together researchers from around the world to solve a hard problem. Martijn Schuemie often shows this picture. And it's very much like us in the sense of people working internationally on a very hard problem, a little different from us because we're missing the $1 billion. Shown in the bottom in the center is OpenMRS, an open source effort to bring medical records around the world. And that is very much like us. Paul Beyondich, one of the leaders of the OpenMRS effort, is also one of the OHDSI leaders and helped us craft our mission and vision statement of how you build an open community. And I think we've benefited enormously from that. As I was writing the opening letter for the Our Journey book, I happened to be watching the opera called Satyagraha by Philip Glass, which is about Mahatma Gandhi and his quest for independence for India and the use of passive resistance. And, you know, if you look at the way he put it together, it's personal conviction, working as a community, and the need for action. And it's so funny, I was writing a letter at the same time, I felt like I'm watching OHDSI. Now, it's preposterous to compare observational research to the independence of a nation, but I think it's important to learn from great things in history. If you think about OHDSI, it's community, collaboration, encouragement, tolerance. We really work well together as a group. The individuals have a generosity of time, they're committed to it, and the preeminence of truth. You know, in some ways, you know, the fact that it took us 7 years to put together Our Journey, a book about OHDSI, shows that we're actually committed to the truth and not just advertising, that we want to get the right answer at all costs. And then the necessity of action. OHDSI started as OMOP, a group that was working on methods, which was spectacular. But then in 2014 is when OHDSI started, December of 2014. It shifted to being allowed to generate evidence. And that is where we took action, and I believe we're having an important impact on healthcare. OHDSI's mission, we always review it, to improve health by empowering a community to collaboratively generate the evidence that promotes better health decisions and better care. And we literally review this frequently as we're making seemingly mundane decisions to make sure that whatever decision we're making leans us towards improving health. OHDSI's values are innovation, reproducibility, community, collaboration, openness, and beneficence. The OHDSI community is shown here. We're now up to 74 countries, over 2,000 collaborators if you look at our forums and our team's environment. We're covering 21 time zones, so we're almost all the way there, and 6 continents, but we're one community working together. Another way to look at it is to look at the organizations that are involved with OHDSI, and they're shown here in alphabetical order. The important thing on this slide is that there are organizations from industry, from government, from academics, from foundations, patient representatives, and so on. So we have good diversity in our community. Kind of make the point about OHDSI in our journey, we have testimonials from OHDSI members. You can read them on your own. I don't want to go through them individually, but what I did is I kind of created a testimonial photo cloud and showed the themes from each one. I'll just read them off. Supporting growth, help and learning, energy and inclusion, inspiration and teams, values and openness, tireless and diverse, doing and sharing, lead and appraise. OHDSI does well because the time everybody puts into it. Shown here are the past Titan awardees. The Titan Awards we created to reward those who put in recognizable extra effort into OHDSI. And while there are many more that can get awards, we still think it's important to reward the community. This year we had over 40 nominees, and thank you to the community for making all those nominations. The categories that we give the awards out are in data standards, methodologic research, open source development, clinical application, community collaboration, community support, and community leadership. Please join us tomorrow for our closing ceremony when you'll hear who wins the Titan Awards. But let me now thank everyone nominated on this list because they're all deserving. OHDSI worked with other groups around the world. We just name a few here. We entered into an agreement with HL7 on March 1st of this year to bring FHIR and OMOP closer together. We've worked closely with the FDA BEST initiative on biological research, most recently COVID and vaccines, the National COVID Cohort Collaborative, that is N3C, with Pioneer and FeederNet, and with the All of Us research program. We've had working groups in OHDSI since the beginning. Although actually early on there was kind of parallel development, the working groups doing their work as well as core members of OHDSI working in parallel on some of the things. And what we've done now is we've become a more mature organization to shift really all of the work into the working groups. What this does is it creates a more transparent organization. So for example, the Common Data Model Working Group is the one responsible for the Common Data Model. That way people can participate in the actual important decisions being made. Our working groups have members. Some are smaller, some up to 241 people, yet they're working together collaboratively and working very effectively to generate output for OHDSI. We also have regional chapters where groups can advance the OHDSI mission, where there are problems that need to be solved locally, coding schemes, language, whatever that is, and those are working well together. We also have OHDSI centers. There's the OHDSI Coordinating Center that I mentioned earlier. The Eden is the European effort that's created a wonderful European data network that is still expanding, and of course the Eden Academy for training. And there's the new OHDSI Center at RU, part of Northeastern University, which will be working on education, on an OHDSI lab, and reproducibility. On community calls, we've had them since the beginning. They started off rather informal, where we introduced new members, did some presentations. More recently, because of our increase in size, we've made them a little bit more formal, providing presentations, debates, community calls, tutorials, brainstorming, reports, and various updates. I strongly recommend these. They're at Tuesday at 11 a.m. Eastern Daylight Time. The next week's call on September 21st is a good one for everyone who's a newcomer to Odyssey, where we'll be introducing new members and letting you meet the community veterans to answer questions. Thank you to Greg Saxon for leading this effort recently. Our study-a-thons have become one of our engines for doing work, bringing people together. You know, usually in a hackathon, there's a bunch of groups competing with each other. We don't do it as a competition, except we compete against time, and I guess compete against falsehoods and irreproducibility. We produce evidence. They last usually a couple of days, and often generate papers that are published in the best journals. One of the ways for those who are newcomers to learn quickly about Odyssey is the Book of Odyssey. This was led by Martijn Schuemie, and then one of those study-a-thons shown below Martijn's picture, the table of contents on the right, basically a tutorial in all areas of observational research evidence generation. So we highly recommend it. It's freely available on the internet. We've had several Odyssey symposiums since our founding. So the 2015 General Symposium, which is usually held in the US, and a series of symposiums, regional, for example, in Europe and the Asia Pacific region. Last year's was virtual, and this year's again is virtual, and we hope next year to come together in person. Now let's look at some of Odyssey's products. One of the best known is the open data standard by Odyssey, the OMOP Common Data Model. This is version 5.4, our current version. This data scheme is an important one. It's both accessible, it's easily to understand for new users, yet it, I think, accurately represents medicine and has been very flexible to allow us to store a lot of information. I think the strength of this data schema lies in the fact that I said earlier, that it's driven by evidence generation. So everything we do is for the purpose of making it easier to generate evidence. Now in the center in orange there, you see the vocabularies, and I'll move to the next slide. We now have almost 10 million concepts in our vocabulary, 75 million concept relationships, 133 vocabularies shown graphically there with their interactions with each other. Put together, this is an amazingly powerful tool for sharing information around the world. It's resulted in 331 databases in Odyssey's federated database. Our data partners now collectively have data on 810 million unique patients. That's a conservative estimate because we are trying to avoid any duplication in our count. It's probably much more than that. But our goal was, with this conservative estimate, to achieve at least 10% of the world's population. We're actually at 11% now. Now, not every data partner gets involved in every study. So in a typical study, we may have several hundred million, and we look to increase the size of this database as well as increase the participation of these databases in each network study. Driving our research is our methods research. That is how we account for causal inference so that we can produce reliable conclusions. And the research here has led to publications in top journals in the field. Once we come up with an algorithm, we then code it in open source software. Our HADES project is the one that coordinates among all these tools to make sure that they work well with each other. The graph on the upper right, shows the use of these tools over time, and there's an exponential growth. Use both within the Odyssey community and outside the Odyssey community, in fact. Then once we have these tools, we put them in a user interface, many of them in the tool called Atlas, where we explore data, design analyses, produce code, and generate evidence. With all these data and tools, we are then able to produce more reliable evidence. This slide from Patrick Ryan shows different versions of reliability: repeatable, reproducible, replicable, generalizable, robust, and calibrated. Those are labels. More important is the center of the diagram, the things that we can change: the question or hypothesis, research or data analysis. And then different versions produce different results. It's important to tease apart all the different components of reliability. Then on the bottom, we see the how we carry out a network study. That is, it starts in one of the nodes and spreads over the network. These are then embodied in a set of principles, the legend principles, shown 10 here, although they may grow or or be consolidated as time goes on, for example, can generate evidence at large scale. Not withholding things from publication, that is making everything available, pre-specified analyses, and so on. We put these together in a methodological approach and then applied them clinically. Our first study, not shown here, was actually in depression side effects, then moved to hypertension. And we presented a lot about hypertension at our last symposium, and they're shown in the publications in the background in some of the world's top journals, Lancet, JAMA, Hypertension. The one in the center is one that we've just published on ACE inhibitors and ARBs, and we're still getting a lot of email led by Ray Chen. And then patient-level prediction. Of course, like every organization is now doing patient-level prediction under the guise of artificial intelligence. Everyone's doing AI. But as we've seen in the literature recently, top EHR vendors sharing algorithms that then in the literature turn out not to be quite so predictive. It's important to have adequate evaluation. What OHDSI has done is tease apart the process from creation of the model through evaluation, each component with diagnostics, so that we can produce reliable predictions and be able to express very explicitly what the expected performance of the algorithm will be. All this work leads to publications. If you start with OMOP and come through OHDSI today, we've put in those papers. You see 344 of them cited in the Journey book. Early on with OMOP, you see about 20 to 40 publications kind of continuing on over the years, and then hitting our stride, doubling that in 2020, perhaps doubling that again this year. Martijn put together a social network analysis of everyone who published an OHDSI paper with at least 2 papers was the criterion, and what were the co-authorship relationships among them. The larger circles indicate more publications. The color yellow means early on in the OMOP days. Green is the beginning of OHDSI, going through blue and purple as we go into present day. If you look at the diagram, you see different groups. OMOP, the early OMOP innovators on the far right. On the left, you see our collaborators from outside OHDSI, N3C, all of us, eMERGE, pCoordinate, I2B2. In the center there, and then the top, we see the oncology group. And then in the center, we see some regions like tools, the common data model, and data quality. However, what I want to emphasize in this figure is not how easy it is to tease it apart, but how hard it is to tease it apart. In fact, that so many people are doing so many different aspects of it. I think one of the successes of OHDSI is that we're not siloed, and that people who work on the common data model also work on evidence generation. So there's a natural feedback loop, so that, in fact, as I pointed out earlier on the common data model, that it serves evidence generation by having people who do many things. It makes it harder to sort out this diagram, but we generate better evidence and better infrastructure to support that evidence. Last year, due to COVID, we went virtual. One of the first things we did was running a study-a-thon in March, which was going to be the European Symposium. Within a couple of months, we put together evidence. We generated evidence that was then used in real policy decision-making. I won't go through in too much detail because I want this, because this plenary session is going to be about COVID, and I'll show that in a moment. But we generated evidence in various ways, culminating most recently in a lot of work on vaccine safety and effectiveness. Our publications for COVID went to the top journals in the world and were used by policy agencies like EMA and FDA. We had some fun publications like looking how changes in policy depend on evidence generation, shown here, for example, the rise and fall of hydroxychloroquine. We have studies in comparative effectiveness and characterization. And as I mentioned more recently on vaccine surveillance, with evidence that was used specifically to, for example, to turn back on the use of a vaccine in Europe. And so please stay with this plenary session to see more details about it. For the rest of this hour, you're going to be hearing network updates from the US, from Europe, and from Asia Pacific. Then for the following hour, we're going to talk about our methods research for COVID-19 and going through that in detail by the people who carried it out. Then after that, about our clinical results for COVID-19, again, going through our history before and then what we've been doing for the past year. And finally, a wonderful panel discussion with experts from FDA, EMA, and industry on COVID-19, both vaccines and the disease itself. Please stay with us. It's an exciting symposium, and I look forward to all these discussions. Thank you. And now I'm going to turn it over to Kristin Kostka.
My name is Kristin Kostka. I'm the director of the OHDSI Center at the Roux Institute at Northeastern University, and I'm delighted to tell you about the growth of our U.S. data network inside of the OHDSI community. The OHDSI community has grown exponentially in my time that I've been involved with our U.S. data network. And it's my privilege to talk to you today about how we continue to expand. Fundamentally, the OHDSI data network is a network of observational research databases standardized to the OMOP Common Data Model. And it's worth adding, it's not one type of data. The types of data represented in our network include administrative health claims, both from our health insurers, as well as hospital charge data masters, electronic health records, both from inpatient and outpatient facilities. We have registry data, biobanks, and our use cases continue to expand. What's most exciting about using the same model is that we have the opportunity to come together to do something great. And that is really something that our community has thrived on continuously. So before I get into the network and how we've grown in the US, I have to say it starts with the people. People are our greatest asset. And the study-a-thon for COVID-19 really catalyzed something special. We are very fortunate that we produced many work products in our 88 hours. But most impressively, we found a way to engage our data network, to talk to data partners, to understand how to get them to be able to use the common data model and to help them with their extract, transform, load journey. And you've seen pictures of our network before. This is a snapshot we've used quite a bit throughout our COVID-19 research. And what's really cool about this is that it's grown over time. And you see that we have a variety of data sources here representing more than 16 million patients. And this is actually, as it turns out, just a snapshot of a tiny corner of the map. There's even more data behind our data network. And that's what today's presentation will focus on. Our network really has expanded because of this idea we want to come together to impact a high value clinical question. So around the collection for COVID-19 data, we had a couple of critical design needs. We wanted speed. We wanted to know while we were experiencing different waves. We wanted to have access to information that was fast and easy, using the same data elements and having a standard way of representing that information. And of course, we wanted to support the science as it was evolving. And so we saw ways to bring in clinical, laboratory, and diagnostic data. And this expansion can really be applied to any use case in our clinical portfolio. And I really think what's most exciting about our network is if you look at it visually, how we have grown from before COVID to after COVID. And right here, you'll see a map that any of you can access that shows the sites that we started with in, let's say, our 2018 census. And these nodes represent a variety of your usual suspects. I see George represented here. I see Nigam. I see Daniela. In 2019, we had a few more health systems like Andrews. In 2020, we had a number of sites come online, and we even got some more representation that was bi-coastal. But maybe most impressively is how much we have grown in 2021. You see here the blue represents the new nodes that have come online in the last year. And we see a variety of sites covered here. We have more geographic representation. We even have a little bit more of the middle of our map filled in. But it also allows us to think about the ways that we need to continue to engage our data partners to better represent different populations at risk. And I know that there are different work groups this year that have really focused on mobilizing around underrepresented health groups and health equity issues. And there are lots of opportunities to tap into this. And so as we go forward in our map, we should talk about the programs that are really helping catalyze the change we see underneath this. So when you see my map, What you don't know is just how much under the surface has been facilitated by big, large-scale initiatives sponsored by the US government. So the National Institutes of Health and CATS initiative has brought together the National COVID Cohort Collaborative, which is responsible for bringing 63 sites worth of data into a central enclave. Many of these are the same dots you see here. A lot of these were brand new sites to OMOP. They may use other data models such as PCORNet or I2B2 or Trinetics, and some are OMOP sites. Everything is harmonized to the OMOP Common Data Model, which means that we can use our concept sets, we can use our cohort definitions, and we have the opportunity to really tap into a giant surveillance network that is following as we evolve with our understanding of COVID. And this is not the only program that exists that taps into representing other parts of our map. The All of Us research program is also catalyzing its own network. So within All of Us, their focus is not COVID-19 specific. They are looking at mobilizing and helping us better represent underrepresented groups in research. And these sites represent community health systems. They represent lots of people who are working on the front lines to take their data from a variety of source systems and convert it to the OMOP Common Data Model. And what's exciting about this is just how much work has been done. So I know the folks at Spectrum Health are a great example of a site that has come on board because of All of Us. And we see lots of opportunity here for both programs like N3C and for All of Us to help us continue to expand our network and to bring in additional sites so that we can have a comprehensive understanding of disease and at scale, not just at our academic medical centers. And you might say, well, Kristin, this is great, but what if I'm a site that wants to join the journey? And there are lots of sites here that have undertaken this process. Anyone can commit to OHDSI at any point in their journey, and they all go through similar workflow. You have to work through the extract, transform, load. You'll have to obviously go through data quality, and then you can get into the fun part of running network research. And so we're really fortunate to have a robust infrastructure as a community to help guide sites through this workflow. We cannot believe how many sites have come online in 2021, and I really look forward to seeing what the 2022 map is going to look like. So if you're a new site in the United States and you're trying to undertake your ETL journey, feel free to reach out because we want you to know that the journey is ours to go with you, and we look forward to seeing our map continue to grow new nodes into 2022. Thank you for your time today. And now I turn it over to our colleague, Peter Rijnbeek.
Hello, I'm Peter Rijnbeek. I'm Associate Professor of Health Data Science at the Erasmus Medical Center in Rotterdam, the Netherlands, and I'm the coordinator of the European OHDSI chapter. And I'm going to give you an update on the network in Europe. Well, thanks everyone. It's really an honor to give you an update on the activities in Europe. So the objective of the OHDSI Europe is to promote the adoption and development of the OMOP CDM and standardized analytics in Europe. In Europe, the need for improved interoperability of data is recognized as a major hurdle to improve the speed and quality of research using observational data. Especially the large number of terminology systems that are used is really a challenge. And furthermore, we need collaboration to develop a common set of analytical tools that enable the generation of reliable evidence on a national and international level. It's therefore not a surprise that the work of the OHDSI community is gaining a lot of attention. The focus of OHDSI Europe is on community building, so a point of contact for all stakeholders, organization of European OHDSI Symposia, and training of stakeholders. The first symposium was organized in 2018 to kick off the OHDSI Europe with the title Bridging Europe. And this was followed by a very exciting meeting in 2019 where the full journey from data to evidence was presented, and we saw an increase in the number of new participants from 27 countries. In 2020, the OHDSI Europe meeting was planned to be at Oxford University under the leadership of Professor Dani Prieto Alhambra, and it was very unfortunate that this had to be cancelled due to the pandemic. Now, these meetings aim to inform the community, create the energy and enthusiasm to participate in the journey. It's really a platform to connect. This also includes opportunities for community members to share their research results and provide demos of their awesome tools. It also offers a space for companies to share their activities and solutions. In the 2 following days, it's all about training, with full-day courses and interactive sessions to learn all from ETL till the use of the tools and standardized analytics. So therefore, I'm very happy to announce that we will meet again for one more exciting journey ahead on March 11th in Rotterdam on a fantastic location. This will be held at the Steamship Rotterdam. The symposium, this will host a symposium including collaborator showcases with posters and software demos. And on the 12th and 13th of March, there will be multiple sessions at the Educational Center of the Erasmus MC for training, but also for working groups or stakeholders to meet. So keep an eye on the communication channels of OHDSI for more information on this, and I'm convinced that the symposium will be fully booked quite quickly. Information will also be available, of course, on the OHDSI Europe website. I invite you to have a look at the previous meetings, and I'm sure you will get excited and do not want to miss to meet the community at a cruise ship next year. So one important activity OHDSI Europe has kicked off is the creation of national nodes within the OHDSI Europe chapter. And the aim of the national nodes is to build on the strengths of stakeholders and the scientific community in a country. So bring people together, give them feasibility within the European and global OHDSI community. We are currently onboarding a German, Spanish, Dutch, UK, and Italian national node, and more are in the pipeline. Information on how to establish a national node is available on the OHDSI Europe website, and it would be fantastic if in the upcoming year we can see more and more channels within the OHDSI Europe Teams environment that's provided by OHDSI Global, and the node leads being actively contributing in the OHDSI Europe Steering Committee that is being formed. So please contact us by email for more information, and we are very happy to set up a call to discuss the onboarding process. I'm proud to share that the OMOP-CDM is booming in Europe. So many European projects are building on the OMOP-CDM, and I'm sure there are even more than those mentioned on this slide. So if you know of more projects, please let us know and we can link up. Also, many new project proposals are being discussed that leverage the OMOP-CDM in the context of the Horizon Europe funding calls. This really demonstrates that the OMOP-CDM is here to stay, and the growing community that is coming from all kinds of disciplines and disease areas will help to further improve the OMOP-CDM and fit it for make it correct for their use cases. The strong position of the OMOP-CDM is also demonstrated by a fast-growing list of studies that inform the European Medicines Agency. So currently, multiple EMA-funded projects are ongoing that make use of the OMOP-CDM. It's also fantastic to see a recent public tender from the EMA for real-world data subscriptions of data sources standardized to the OMOP-CDM to be used internally at the agency. That brings me to the biggest project in Europe that drives the adoption of the OMOP-CDM, the European Health Data and Evidence Network Project EDEN. This project is building a large federated data network of databases standardized to the OMOP-CDM. It's not only about improving interoperability, but also to build analytical tools and apply them in studies. The consortium led by Erasmus Medical Center and Janssen Research and Development consists of 23 public and private partners and is funded by the Innovative Medicines Initiative. The EDEN project is in its 3rd year and will continue till April 2024. In parallel, EDEN is setting up a legal entity that will be launched soon to make sure that the output of the project will be sustained beyond the project lifetime. So one of the very nice deliverables of the EDEN project is the EDEN Academy, an online platform that contains many courses, for example, on how to standardize your data to the OMOP-CDM. And the EDEN Academy allows us to scale up the training, and this is needed, as shown by the more than 1,500 students from 64 countries that learn a lot from this resource. I can highly recommend to have a look at the EDEN Academy at academy.eden.eu. So the Academy plays an important role in training and certifying small and medium enterprises in Europe. And by the end of September, almost 50 small to medium enterprises will have gone through a certification process that includes online training and a certification session in which an actual data source has to be mapped. It's really fantastic to see the activity of these SMEs in Europe in mapping data. The support network they are creating is highly valuable for the growth and sustainability. And moreover, they help to grow the network through their connections with data partners. And Eden is providing financial support for data sources up to €100,000 to standardize their data to the OMOP Common Data Model with the help of the certified SMEs. And there is an impressive interest in Europe to get on the OMOP CDM, and Eden has selected up to now 98 data partners through this open call process for funding. So it's a pleasure to announce that there will be a new call initiated in October with a budget of €3 million. And we especially invite data partners from countries not yet represented in the data network to apply, and data sources with longer term follow-up linked to inpatient data. There's also an interest in autoimmune and inflammatory disease and implantable device data. For more information, keep an eye on the Eden website, where the call document will be available that fully describes the selection criteria and process. With that, I'd like to end my presentation, but not without thanking the very large group of Europeans that joined our exciting journey. And I look forward to finally meet face to face again next year in Rotterdam. So keep up the great work, and thanks. Okay, I'd like to turn it over now to Mui Van Zandt.
Hi, my name is Mui Van Zandt. I work for IQV as a senior director, but today I'm here as an OHDSI global leader for the Asia Pacific community, and I'm going to review with you guys all the activities and the highlights of Asia Pacific in 2021. So what I would like to start off with is to show you a little bit about all the different chapters that we have in the Asia Pacific region. We have South Korea, China, Japan, Australia, Singapore, and Taiwan. Our goal this year has been to focus on OMOP conversions and making a lot of the data that's available in these regions and turning them into OMOP so that we can use them for further research. Some of the highlights from the actual Asia Pacific as a chapter itself is, you can see here, is we have quite a few sites that are either already in OMOP or working on taking their data and OMOPing them in the different regions. As well as, one of the things we started this year are bi-weekly APAC community calls. They are Wednesday night at 11 a.m. Eastern Standard Time. And they cover many different things, very similar to the OHDSI APAC weekly calls. We cover overviews, we have mini tutorials, we have little discussions, project discussions. So if you have an interest, please join us there. And this year, we've done our first ever Asia Pacific ETL training class. It's a 2-day course that ran in August. And we had such great participation that we actually ended up with 65 folks overall, over both days and virtually. And the feedback from there is quite positive. And then we also, which I will talk about in a little bit, did our first ever Asia Pacific network study that involved quite a few of the different countries above and beyond some of the research that the different teams and the different chapters are doing themselves. So now I'm going to go a little bit into each of the chapter and what some of the highlights from there. So to give you a little bit about Korea. We spent, the Korean team started the FeederNet network a few years ago and had a target of 60 different hospitals in here. As of right now, they have 46 of the hospitals already in OMOP, as well as taking this year the HERA data, which is the national claims data, and moving that into the OMOP model as well. As you can see over here, they have quite a few collaborators joining the network and joining them, all the way to the point where I think some of these folks have even now talked about taking their ETL to the next level, which is actually making daily increments instead of full refreshes. That's something I know the Korean community is looking at. Moving on into China, one of the initiatives that took place in China this year is actually try to separate the group, because they were so huge, into 3 different subgroups to help better organize the activities that are going on there. And as a result of that, we have quite a few folks that are now taking their data and moving them into OMOP. As you can see here, we have 8 databases that are in OMOP and ready for collaboration. And some of the folks have actually now started participating in different OHDSI studies like the COVID research. And we have 2 actively contributing studies where the data is being utilized. In Japan, they have monthly calls now that they have been set up. And in this group, their objective is to better understand what resources are available to them to help them do OMOP conversions. So as you can see here, they have started things like translating the Book of OHDSI, looking at Usagi, as well as working on efforts to do their vocabulary mapping. They're now in touch with the vocabulary team about moving their drugs over to the OHDSI Athena tool, as well as approaching different stakeholders to understand how and what they need in order to move their data into OMOP. Okay, moving on to Australia. There's a lot of activity going on here with a lot of different conversions. As you can see here, they're converting data from secondary care, converting data from primary care. They are actually, actively working on 5 different conversions and actively participating in quite a few publications. Some news that we want to highlight here is they have a lot of webinars that happens on a regular basis, so look out for that if you want to learn more about that, as well as they've received funding from the Australian Research Data Commons and the NHMRC to take some of the data that they have and make them research ready and put them using OMOP as the underlying platform to get the data into a research ready environment, right? Singapore, here we have, they've actually last year taken some of the data and moved that into OMOP, but above and beyond that, they want to take that and apply it to different areas. And they've recently actually done a feasibility study, and it's now accepted into the AMIA Applied Clinical Informatics Journal. And they've actually worked with the government institutions that are over there and looking at plans of adapting OMOP as the underlying platform for a 9-hospital, all of their hospitals, a research-ready program over there. And they are participating in our APAC hypertension study that I'm going to talk to you about in a bit. Finally, but not least, is our Taiwan chapter. They are quite new. And they've actually last year taken all of the data that sits within the Taipei Medical University and transformed that into OMOP, and it is now in a research-ready state. Their goal this year actually is to bring more awareness to the community and to the folks in Taiwan and different academic institutions there on what is OMOP and what is its capabilities. So if they set up a website for folks to better understand the Taiwan activities, as well as the group is actually actively talking to different universities from the different regions about what is OMOP and how this can be utilized and what the benefits are there. Last but not least, I do want to talk about our first ever Asia Pacific study that goes across multiple Asia Pacific countries. And this is the APAC hypertension study that we started last year. And right now we're at a finished phase 1. And phase 1 is now out there for publication. As you can see here, we used data assets from 5 of the 6 different chapters, with Japan wanting to join us next year. And we've not only done a characterization on it, but we've actually went through and did some treatment therapies. As you can see, these are some of the results from the different countries in the Asia Pacific region. Like I said, right now we are putting this through publication, and hopefully you'll see it in a publication journal soon. Please go enjoy your 10-minute break, but don't go too far. Make sure you come back for our next section on methods research on COVID-19.
Hello, welcome to the section. This section is devoted to the methods research in COVID-19. My name is Ostropolets, and I'm a PhD student at Columbia. And today I'll start this session with presenting our work on the background rates and their sensitivity to the different design choices. So over the past year, we experienced a massive vaccination campaign, with some of the countries vaccinating more than half of their population. And COVID-19 vaccines saved thousands of lives. But with the growing number of vaccination, we have the growing number of safety concerns, which requires rapid yet robust vaccine safety studies. And such studies rely on two pieces: observed incidence rate, which reflects incidence in a vaccinated population, and expected or background incidence rate, which reflects baseline incidence in a population. And we make judgment about safety based on the ratio of these two numbers. So it's important not only to accurately gather adverse events reports, but also to accurately compute background rates. And you may think that this is a trivial task. You just divide the number of new cases over a specified time period by the percentile of at-risk population. But when we actually start to ask ourselves the questions related to each piece of the equation, this is when it gets complicated. For example, how do we define new cases? Or where do we start our time at risk interval? Or which time at risk interval do we select? Or which population? And you can see this example of heterogeneity that comes from all of these moving parts and this simple example. So the incidence, the baseline incidence of stroke in different studies, it varies by up to a factor of 100, depending on all of these moving parts. And even more, we don't really know how changing all of these parameters influences the baseline rates. So to answer this question, we systematically examined all of the design choices related to each part of the equation. We selected 15 adverse events of special interest from the Brighton list, and for each event, we computed incidence rates with A, varying mechanisms for defining new cases, B, different approaches to time at risk interval, such as time at risk anchor, different time at risk duration, different time at risk year and season, and C, different target populations and subpopulations. And all of these individual small experiments were conducted on 12 data sources, and the output of each experiment was either incidence rate or incidence rate ratio. And additionally, we conducted a meta-analysis across all outcomes and all databases. And we have a lot of results, but here we will focus on three main groups: influence of demographics, influence of anchoring, and temporal and seasonal trends. First, let's talk about demographics. Let's continue with our stroke example. What you can see here is on x-axis you have different age groups, and on y-axis you have incidence rates. And we can observe that there is a clear age pattern for stroke, with incidence in elderly more than 100 times higher than incidence in children. And this is of course not surprising, but what is surprising is that we observe the consistency across all databases. And moreover, we observe consistency across multiple outcomes. And the difference is really striking because the difference between age groups is large. Then when we go to sex and race, we observe only moderate effect. What you can see here is the incidence rate ratio of incidence rates in males compared to incidence rates in females. So whenever incidence rate ratio is higher than 1, it means that rates are higher in males. And whenever it's lower than 1, rates are higher in females. And for non-hemorrhagic stroke, we can see that it's of course more common in males as we expected. But the magnitude of the effect and the magnitude of the influence is small compared to the influence of age. And the same with race, not depicted here, but you have the numbers in this box. We do observe some influence of race for some of the conditions, but the magnitude of such influence is small. Next important point, which has not been studied before, is the anchoring. So for unexposed group, we don't really have a clear point in time where we start our time at risk. So researchers usually use something like an arbitrary date, such as January 1st. But what if we select a different anchor, such as visit? And what you can see here on x-axis, you see the different time at risk windows, and on y-axis, you see the incidence rate ratios of incidence rates when anchored on the visit versus anchored on January 1st in a patient with a visit in the next year. And when we look at stroke, we see that for short time at risk window, incidence when anchored on the visit is 30 times higher than when anchored on a date. And we observe this pattern consistently across all databases. And more importantly, we consistently observe this effect across all outcomes. So whenever you anchor in the visit, it produces a much higher rates when compared to anchoring on a January 1st or any arbitrary date. Then when we continue to look at the different time at risk windows, again, we can observe the short time at risk window produces higher incidence rates than other time at risk windows. And this is especially important when you're studying acute conditions. But we observe this effect only when we anchor on the visit or other healthcare encounter. When we anchor on a random date, we do not observe a great difference across different time at risk windows. So it doesn't really matter if you select 90 days time at risk window or 28 days time at risk window, the incidence rates when anchored on a date will be more or less similar. Then let's talk about seasonal trends. So compared to all of the factors mentioned before, seasonal and temporal trends do not play a great role in incidence rates. We do observe that 2020 has a decreased incidence compared to previous years. And then only some of the conditions display seasonal trends, like for example, anaphylaxis. But still, you can see that the magnitude of effect is rather small compared to age or compared to anchoring. So to summarize, age is the one most important factor that influences incidence rates. We observed that incidence rates vary up to a factor of 1,000 across age groups. And gender and race also do play a role, but they have moderate impact on incidence rates. The next most important factor is anchoring. Anchoring influences incidence rates a lot, and you observe higher incidence rates when anchored on a healthcare encounter compared to anchoring on a random date. Also, we observe that temporal and seasonal trends do exist, but their influence on the incidence rates is moderate. And there are also some key implications for researchers who want to study, to interpret, or to compare baseline rates. First, we really want to ensure that the population that will be used for observed rate calculation matches the population used for baseline rates. For example, if it comes to age, we may want to do age stratification, or we just want to ensure that the age distribution is similar across different groups. Second, again, as the background rates don't have a clear point in time to anchor their patients, we must select an anchoring or the index date or event that represents our exposure best. When we talk about vaccine safety studies, we really want to ensure that our anchor in the unexposed group matches the vaccination best. And with that, I would like to conclude my presentation, and I'm happy to answer any of the questions that you might have. And also, please check out our upcoming paper for more results. And I would like to turn it over to our next presenter, Rupa Makadia.
Hi, my name is Rupa Makadia, and I'd like to share with the community our work done on phenotype sensitivity in regard to the adverse events of special interest for COVID-19. The development of a phenotype is the backbone of any research we do in OHDSI. Time and time again, we have assessed how to develop phenotypes that are reproducible and accurate. In the context of COVID-19 research, we needed accurate phenotypes for each adverse event of special interest that could be reproducible in a large variety of databases. As vaccines become approved and safety monitoring protocols were written, we saw the FDA CDC, and the Access Network provide us their definitions for each adverse event of special interest. While the community always appreciates a sneak peek into how others may define a particular phenotype, we know that observational data is diverse and its ability to be reproducible in all data sources and data types, such as claims or EHR, was unknown. Let me walk you through an example of an AESI that has been studied widely in the vaccine space and in observational data. Guillain-Barré syndrome, or GBS. The FDA's protocol stated that GBS be defined by one ICD-10 CM code on a claim that occurs in an inpatient setting and in the primary physician. While the CDC also defined GBS by the same code, it stated that the diagnosis can occur in any inpatient or emergency room setting, further broadening the definition. The Access Network then applied a broad and narrow definition for its calculation of background rates, which is a definition that also allows all place of service settings. While all three phenotypes look and sound valid, we are left to decide which to implement with no empirical evidence of the trade-offs we make by selecting a particular definition and its effect on the background rate. This leads us to the main objective of this research: to address phenotype sensitivity using a systematic method to empirically evaluate alternative phenotypes to assess the effect on background rates and cohort composition. We utilized the 15 phenotypes that were presented in Anna's work and derived a base definition and then at least one alternative or multiple definitions. For brevity and ease of understanding, we present 2 cohort definitions per phenotype. The differences between the cohorts largely can be categorized into 4 major differences. Differences by place of service, so the concept sets remain the same, but the place of service changes. In the second category, the concept set expression changes along with the place of service. The third category shows the changes by the concept set expression. And the last category is an evaluation of the shifting of the index state based on what we observe in the data. The cohorts were developed in Atlas, and we utilized cohort diagnostics to systematically evaluate and compare the characteristics of each cohort. The background rates were calculated using a time at risk of a 365-day period following the index date. People contributed time at risk from January 1st to December 31st for each qualifying year in 2017 to 2019. We compared the overall incidence by database for the cohort pairs in each of the phenotypes. Cohort diagnostics is a standardized package in Hades, and for an in-depth demonstration, please see Dr. Gautam Rao's software demo. For the purposes of this research, I will focus on some main analyses from the tool and compare the cohorts using the GBS example. Cohort counts by database. This helps us address the sensitivity trade-offs we make in terms of patient counts and events. In our GBS example, applying restrictions on place of service reduced our cohort patient counts and events over 30% across databases. The incidence rate stability plots show the incidence rate over time and can help us address any changes over time and help us understand rates by age and sex. In our GBS example, we see a higher incidence rate for males and people of older age, which is expected. Cohort overlap helps us understand the patient population overlap in both cohorts. In our example, we saw 31 to 47% of patients overlap between the 2 definitions across databases. We can also compare the temporal characterization to compare cohort composition by each covariate in the database in different time windows to see how similar or different the cohort characteristics are. We can dive a little deeper into the results of comparing the cohort characterization by reviewing standardized difference plots from the baseline characteristics of both cohorts. We can take a look at one claims database, the Optum de-identified Clinformatics data mart, for each category of phenotypes and observe how similar or different these patient characteristics are. We see from these plots that for anaphylaxis, we see a very different patient profile between the 2 cohorts. Even in our example of GBS, we see some differences in the patient population. While some of these differences are attributed to the setting, such as codes utilized in a hospital setting, as seen by the yellow dots, we also see differences in other pain-related codes that are more prevalent in the IP GBS cohort. Appendicitis shows good concordance among the two populations, which may be expected understanding how the disease is treated and diagnosed. We see similar patterns of variation when we vary the concept set expression and place of service for the stroke definitions. Non-hemorrhagic stroke in the IP setting have codes that are related to place of service, the yellow dots, and then having additional underlying cardiac conditions that make up that population. Code set variation may or may not lead to differences in cohorts, depending on the influence of the code. For the 4 cohorts displayed here, we see differences for those in the Bell's palsy that include unspecified codes for other facial nerve disorders compared to using the Bell's palsy code alone. Shifting the index date theoretically shouldn't change the patient population, but rather try to capture the first point in the database where we see indicators for the disease. In the case of transverse myelitis, we capture key symptoms related to the diagnosis of transverse myelitis, and then follow those codes by a code of transverse myelitis within the 30 days to confirm that the diagnosis code has indeed appeared in the database. As shown here, these cohorts yield a very similar characteristics. We calculated overall background rates to see the impact of changing the phenotype by database for each category of phenotypes. Here, the place of service variant rates. On the left is cohort 1 and on the right is cohort 2. We're able to see a shift either up or down, and the slopes of these lines give us an indication of how dramatic the shift can be for a given database. For GBS, we see a large shift in the incidence rate, but in Medicare, smaller changes for some of the other claims databases. CPRD and JMDC don't have inpatient data, so that phenotype wouldn't be evaluated in those databases. In the place of service variant, we see an overall downward shift in the background rates, larger for some of the databases. For the remaining categories, we see smaller shifts in the background rates. For the stroke definitions, the greatest impact are those in Medicare. While the narcolepsy phenotype, we did not observe much of a difference between the cohort composition, we see a downward shift in the background rate when we exclude hypersomnia events from the past and on the index date. Our research describes a method to empirically evaluate phenotypes using standardized tools to derive insights about cohort characteristics and understand the trade-offs in sensitivity, specificity, and misclassification of index events. From this work, we can observe that patient characteristics can vary widely and differ by the types of change, such as changes of place of service or concept set expressions. We observe changes in the background rate, and it varies by database and definition. This work highlights the need to be able to have empirical assessments to better understand definitions that may be used in the calculation of background rates and future safety analyses. Thank you for your time, and a special thanks to the Vaccine Safety Work Group. Now I'm going to turn it over to Martijn Schuemie.
Hi, I'm Martijn Schuemie, and on behalf of the EUMAEUS task force, I'd like to present an overview and the main results of the EUMAEUS experiment. So EUMAEUS stands for Evaluating Use of Methods for Adverse Events Under Surveillance. The background behind it is that, as you all know, many people are now being vaccinated against COVID-19, and we need to ensure the safety of these vaccines. And currently that's primarily done through spontaneous reporting, but there are some challenges with that. For example, underreporting, the lack of a good denominator, and as Anna explained earlier, it can actually be quite hard to define what the expected rate is for these observed spontaneous reports. Another source of information that we could use to learn about the safety of vaccines is existing healthcare data, such as administrative claims and electronic health records. However, one challenge there is that many epidemiological designs have been proposed, but it's actually quite unclear how these methods perform. And so this is where EUMAEUS comes in. So EUMAEUS is an empirical benchmark study, in some ways quite similar to a benchmark study that we've published in the past in the Harvard Data Science Review, which was aimed more at drug safety. So EUMAEUS has as goal to systematically evaluate the performance of methods to reliably identify vaccine safety signals in a real-world setting. Now, in order to achieve that goal, we've designed EUMAEUS as follows. We have a set of methods that we want to evaluate. This includes the case control design, propensity score adjusted cohort analysis, where we're comparing vaccinated people to unvaccinated people in the same time period. We have the historical comparator design, where we're comparing the rate during vaccination or after vaccination to some incidence rate that was computed in the same database, but 1 or 2 years before that, as well as some more advanced designs like the self-controlled case series and the self-controlled risk interval method. So of all these methods, we also include several different variations as we've observed them in the wild. So these are variations of these methods that are actually, as they're actually being used to monitor safety of vaccines. So we apply these methods to 4 databases that we have access to, 3 insurance claims databases and 1 electronic health record database. And we've defined a set of exposures and outcomes. The exposures in this case are past vaccinations. So for example, the H1N1 pandemic vaccinations or the seasonal flu vaccinations that took place in the 2017-2018 flu season. We also defined a set of outcomes, in this case 93 negative control outcomes. So these are real outcomes that we are fairly certain of that they're not caused by any of these vaccines. And so therefore we would expect the true effect size to be null. And in addition to that, we have positive controls. Unfortunately, in an experiment like this, using real positive controls is difficult for various reasons. So we use simulated positive controls where we simulate that these outcomes are caused by the vaccines with a pre-specified effect size. And so we can apply these methods to these data for these exposures and outcomes where we know what the true effect sizes are, and we can test whether or not the methods are able to find the truth that's in these data. And based on that, we can compute various metrics of performance of the methods, such as type 1 error, which is 1 minus the specificity, type 2 error, which is 1 minus sensitivity, and time to detection. And I'll tell you more about these metrics later on. Now, of course, like all OHDSI projects, EUMAEUS is an open science project, so we pre-specified and registered our protocol. Our analysis code that we use to execute the experiment is available as open source on GitHub. All the results are publicly available through Shiny app. We have weekly meetings that are open to all. And we've already written 2 papers that are out on medRxiv with many more to come. Okay, but let's dive right into the results. So one of the things that immediately strikes you when you look at the EUMAEUS results is that even with the same data and answering the same question, but using different methods, you can get very different results. So here I'm showing you a single example where we're looking at H1N1 pandemic vaccinations as exposure and contusion of toe as an outcome, where this is a negative control. So we firmly believe that these vaccines do not cause a contusion of toe. And therefore, the true effect size should be equal to 1. But we can see here that these 4 example methods that I've selected actually produce very different effect sizes from one another and from what we know to be the truth. 2 of these methods actually report quite large harmful effects for contusion of toe, where instead we actually know that the true effect size must be around 1 as indicated by the dashed line. Now this is just, of course, one negative control, and we have, as already explained, many negative controls and many positive controls. And so we can repeat this process for all these controls and produce a overall estimate of the performance of these methods. And so what I'm showing you here is, again, for these 4 example methods, the type 1 and type 2 error. So starting at the center going left, I'm showing type 1 error, and starting the center going to the right is the type 2 error. Type 1 error is a measure of the number of false positives. So it tells you of all the situations where there is actually no causal effect, how often does a method declare that there is a signal. Type 2 error is the opposite. So for all of those situations where we simulated that there is a true causal effect, how often does the method not signal that there is an effect? In this case, I declared something to be, or I used as a definition for a signal, simply that the p-value had to be below 0.05. And because of that, we would expect that the type 1 error actually is 5%, because that's our defined alpha threshold. And as you can see, some of these methods actually have type 1 error that is much higher than what we had specified. Specifically, the case control design and the historical comparator tend to generate many false positives, even though, for example, the historical comparator is adjusting for age and sex and is using historical instance rates that come from the same database that we use to define the observed count. Now, what is a little bit complicated here is that both type 1 and type 2 error are varying. So even though historical comparator has the highest type 1 error, it has the lowest type 2 error. So which method should we prefer? Because we might want to find signals more quickly or miss as few signals as possible. But do we want to accept a higher type 1 error rate for that? But on the flip side, the SCCS method, for example, has higher type 2 error, but we could easily make that lower by, for example, raising our alpha threshold. Now, one way to make all of these methods much more comparable is by using something that we've proposed in the past, an approach called empirical calibration, which can be used to fix our type 1 error. So very, very briefly, what is empirical calibration? Well, basically, it starts by using the negative controls and the estimates that a method produces for those negative controls to get a sense of how much error, systematic error, is inherent in the method. And this systematic error can be due to confounding or, for example, measurement error. We cannot actually distinguish between that, but we can get some sort of a idea of, given where all the negative control estimates are, does it tend to be more positive or more negative or more spread out? Once we have this estimate of the uncertainty around the systematic error in a design, we can incorporate that into our p-values and our confidence intervals. And this is actually described in the papers that I'm showing you here. Now, when we apply this empirical calibration to these methods, we see that indeed we actually get type 1 error much closer to nominal. So the red bars here indicate the type 1 error after calibration, and for all methods, these are now quite comparable and close to the 5% that we would like to see. We also see that because we had to make some adjustment, the type 2 error for some of these methods actually increases. And of course, the more type 1 error there was to begin with, the more type 2 error we have to accept now. And we see that now, after calibration, the SCCS actually has the lowest type 2 error because it actually had very little systematic error to adjust for, and the type 2 error did not change. So it seems that taking into account the systematic error that is inherent in a method, in a design, and as it is applied to data is an important thing to do in vaccine safety surveillance. However, it is not the main concern that you often see in vaccine safety literature. There, the main concern is about error due to sequential testing. So in a regular setting of vaccine surveillance, as the vaccine is rolled out, what one typically does is look at the data over and over again as more data accrues, as more people are vaccinated. So we might look at the data once every month or once every 2 months. And because you are doing multiple testing, that actually could lead to a high false positive rate just for that reason, because of the multiple testing. There's actually been a proposed solution to this, well, multiple, but I would say the main accepted solution is a procedure called max SPRT, or sequential probability ratio testing, that can adjust for this sequential testing. So let's see what effect it has. So here I have an example where we're looking at the type 1 error of the historical comparative design in a specific setting, where we look at the data every month for 9 months. If we don't adjust for sequential testing and we don't do empirical calibration, we get a type 1 error of 28%. So that's very high. A lot of false positives are coming out of this method in this way. If we apply max SPRT to account for the multiple testing, the sequential testing, the type 1 error drops to 18.3%. So that is substantially lower than it was, but still quite high. If instead we do empirical calibration but don't adjust for sequential testing, the type 1 error becomes 10.8%, so also still high. But actually we can do both. We can use empirical calibration to adjust for systematic error, and we can use max SPRT to adjust for sequential testing, in which case the type 1 error becomes 6.5, which actually 5%, which actually with these numbers is as close as you can get to the nominal 5% that we specified. This last approach, where we can combine empirical calibration with max SPRT, is actually a new development that we achieved, and we're actually busy writing a paper about how that works. I would like to point out that I find it very interesting that the adjustment for systematic error actually had a bigger impact on the type 1 error than adjusting for sequential testing. That's not to say that one is more important than the other. I'm just saying that you should do both to get your type 1 error under control. Now, using this approach, so both adjusting for sequential testing using max SPRT and adjusting for systematic error using empirical calibration, we can now ask the question, well, how long does it take to detect signals? And so here I'm showing you on the x-axis the number of months it takes to achieve 50% sensitivity, so to signal or identify 50% of the positive controls that we included in our data. And here I've stratified this by true effect size as indicated by the colors. So in the top, we see that the match case control design actually never achieves 50% sensitivity. Even after 9 months, it's not at that level. In contrast, the self-controlled case series, for larger effect sizes, very rapidly achieves 50% sensitivity. So it has the shortest time to detection for larger effect sizes. However, even the SCCS design has not detected 50% of all the positive controls when the true effect size is 1.5. So that actually is an issue that we need to take into account. So we didn't just, of course, do this for these 4 methods and this one exposure. We did this for all exposures, all methods, all databases. The pattern seems to be fairly consistent as what I just showed you. So in conclusion, the EUMAEUS experiment suggests that many methods show large systematic error or type 1 error, which is something that we need to take into account. Empirical calibration can restore type 1 error to nominal, but sometimes at the cost of increasing type 2 error depending on the magnitude of the systematic error that we detected with our negative controls. Empirical calibration often has a bigger impact than adjusting for sequential testing, so I would recommend we do both. And after calibration and adjustment for sequential testing, the SCCS seems to be the overall best in terms of shortest time to detection. However, no method achieves high sensitivity for small true effect sizes on these data. So we may actually need either bigger data, combined databases, or maybe accept a higher false positive rate. That's it. Thank you. Okay, so now I would like to hand it over to Faaizah Arshad.
Hi, my name is Faaizah Arshad, and I'm an undergraduate student at UCLA. I'm excited to be presenting on one study emerging from EUMAEUS, which is why sequentially combining a sensitive and specific epidemiological design does not improve signal detection. Before I begin, I'd like to thank the entire EUMAEUS task force for allowing me to lead this part. It's been an honor and an invaluable learning experience to collaborate with them. In this presentation, I will first introduce you to our research question, then share our findings before and after empirical calibration, and finally conclude with an interpretation of why we believe our results are the way they are. As Martijn previously mentioned, over 5 billion COVID-19 vaccine doses have been administered worldwide. And with this rapid increase in COVID-19 vaccine uptake, it has become increasingly important for post-vaccine surveillance systems to monitor signals for vaccine safety. Traditionally in epidemiology, there's been an intuition that combining sensitive and specific methods will improve signal detection. The process first uses a sensitive method to generate a signal, and then applies a specific method on anything flagged as a signal to verify if a causal relationship actually exists between a vaccine and adverse event following immunization. And this is particularly relevant to OHDSI because the methods that we implement tend to be applicable to various research questions, and any method that, such as the self-controlled case series, can be used in signal generation and applied to many outcomes. So in our study, we sought to test the hypothesis that sequentially combining epidemiological designs is favorable. And for this, we selected one design expected to be sensitive, the historical comparator, and one expected to be specific, self-controlled case series. Then we computed the type 1 and 2 errors before and after empirical calibration. I will start by sharing type 1 and 2 errors before empirical calibration for one exposure of interest, H1N1 PDM 2009 vaccination in the Optum Electronic Health Records database. So here we can see that the historical comparator method is highly sensitive because it has lower type 2 error than the self-controlled case series, while the self-controlled case series is highly specific. But when the methods are combined, we would expect high sensitivity and specificity, but we actually find that sensitivity decreases and specificity increases. If we zoom out and we view type 1 and 2 errors before empirical calibration for all outcomes across all 4 databases, we find that generally using a sensitive method followed by a specific method doesn't compensate for the individual flaws of each method alone. Another interesting finding is that unlike our initial expectations, we actually find that there are cases where the self-controlled case series is in fact more sensitive and the historical comparator is more specific. When we apply empirical calibration, we find that type 1 error returns to nominal, so it's closer to 0.05, while type 2 error increases. But even with empirical calibration, combining the historical comparator with the self-controlled case series using a serial approach, again, does not improve sensitivity and specificity in the way we expect. This is consistent across all 4 databases, showing that type 1 error returns to nominal and the combined method is not desirable. So clearly our findings oppose the widespread recommendation to implement a sensitive then specific method in signal detection, particularly for vaccine safety surveillance. And while we're still working on interpreting this data, we think that one possibility for these results is that The self-controlled case series method generally performs well in comparison with other designs. So using the historical comparator in front of it perhaps deteriorates overall performance. Thank you. I will now hand it over to Jenna Reps.
Hi, I'm Jenna Reps. I'm going to be talking about prediction sensitivity to data and design choices. So we've been developing our patient-level prediction framework and tool over the last 5 years. And we've got this framework that has best practices, and we have an open source implementation. So if you go to the GitHub /OHDSI/patient prediction, you can actually access all our tools. But effectively what we've done is we decompose the prediction problem, any prediction problem, into 3 components: the target population, the outcome, and the time at risk. And we've done this so that it's very transparent what we're actually predicting. So we have this all here, but what we're finding is that a lot of prediction models are failing to make any clinical impact. And there's various reasons for this. So the main one is that there's methodology issues, but we've been doing a lot of work into best practices. So we've kind of solved that, or at least we know the limitations. And we've been trying to develop that over the last few years, and we're still ongoing. So we've kind of ticked that box. And then there's the issue of lack of external validation. We've also ticked this box because we have the standardizations, we have the standardized data, we're able to do external validation at scale. So we don't really have these 2 issues with our framework, but what we're finding is that we're still getting issues with people not trusting the data. So people don't think that we're correctly identifying the outcome, or we're not identifying the target population. They question whether the models we're developing can be transported into different settings. So we decided to do an experiment to actually see, how do we gain trust? And one of the ways we could actually see whether we can to improve the trust in predictions is to see what is the impact of an outcome definition of phenotype. What is the impact of the target population on a prediction? So we wanted to look at the stability. Does changing an outcome definition or the target population change the performance of the model? And if not, that can give us confidence that we can maybe transport those models to different settings. If they're unstable, then we've probably got some issues and we need to make sure we're getting the best definitions possible in our data, or maybe it's just not feasible in our data. So we developed an experiment to test this. We focused on COVID vaccine outcomes of interest. We didn't actually predict anything in COVID data. So we just used these as prediction tasks of interest. So we had 9 different outcomes. For each outcome, we had 3 to 4 different phenotypes, so different definitions, different ways of identifying that outcome in our data. We looked at 3 different target populations. We looked at people with an influenza vaccine visit in 2017, people with a random visit in 2017, and people with, basically the general population with a January the 1st, 2017 index date. So we had 3 different target populations, 7 different databases. Our study protocol is online. There's a lot more detail if you're interested. If you go to this protocol, OHDSI studies, GitHub, and then you go to COVID-19 vaccine prediction, and you'll see the whole methodology there. But in summary, what we did is we developed a lot of models. So here I'm just giving you an example for one of the prediction tasks, which was acute myocardial infarction and acute MI. And you see on the rows, we got different target populations that we investigated, and along the columns, we got the different outcome definitions. So we started off with a very broad acute MI definition. Then we kind of got a bit more specific, where we said it had to be an inpatient setting. And then we changed the way we were defining the acute MI and required that it had to be an inpatient definition. So we had different phenotypes for the outcome, different target populations, and we developed the model for all of these different combinations. So this is just for one data set and one outcome, but we actually did this for 7 databases and 9 outcomes. So that's why we ended up with a large number of models. And the reason for this is we wanted to see how similar in performance is the acute MI model, where we're quite broad, trained in a target population of January the 1st. So this model, how does this compare to a model that we used the more more specific outcome, the acute MI inpatient, definition 2, and we applied it to patients with a flu visit. So are these similar, yes or no, is what we wanted to investigate. But we didn't stop there. Because we have our framework, our standardizations, and we can do external validation at scale, we also wanted to ask the question of how does a model perform when you externally validate it across these different definitions. So I've given you here for an example for one of the models. So a model trained on CCE to predict the more sensitive MI definition within 1 year of January the 1st, 2017. We developed this model, but then we applied it to all the different phenotypes for the outcome and target population combinations. So we have 9 different outcomes and target populations here. But we didn't stop there. We did this per database as well. So we really scaled up the external validation. Normally, when someone does external validation, they use the same definition for the outcome and the same target cohort. We did external validation on a different data set, and we also looked at how sensitive that was to changing the outcome definition slightly and changing the target population. So we had over 60 validations per model. So 500 or more models, 60 validations. We have a lot of results here, but we can see how stable the performances are. So here are the first results. There's a lot of results, as you can see, as I mentioned, but here we've got the outcomes. So the tasks are the columns and the data sets are the rows. Now this is model development. So each rectangle here is broken up into the target populations and the phenotypes for the outcome. So the first phenotype, second phenotype, third phenotype. So this first cell here is a model trained in CCAE to predict the acute MI with the first definition, which happened to be the more sensitive definition. And then for patients who have a random visit in 2017, this is the first cell. And then the next cell, we actually were doing the similar prediction model, but for the second phenotype of the acute MI. And then the row cell below, we were doing a similar prediction with the same outcome phenotype, but with a different target population. So we see here that we've got quite similar performance. And this is what we saw for certain prediction tasks. Each of these blocks had similar colors, which suggests to us that the model performance was pretty similar across outcome definitions and across target populations. So we got stability here, but we didn't see this all the time. In some situations, the target population actually made an impact. So IQVIA Germany, the flu vaccine target population actually didn't do as well as the others. And this may be because in Europe, flu vaccination sometimes is given to people who are actually more sick. So that may be why we're seeing this observation here. So we actually see some situations where we don't have stability. And some of the outcomes, we didn't have stability at all. So changing the outcome phenotype and changing the target population really changed the performance in some of these outcome tasks. And this may suggest that these tasks, either they're not suitable for us in observational data, or we need to be very confident that we've got the right phenotype for the outcome and the right target population for where we're applying the model. So we also have the external validations. We have a lot of data. I've just picked out one of the tasks, but if you wanted to look at the results for all the other prediction tasks, the 8 other outcomes, you've got the full results at data, odyssey.org, patient level prediction repository. So for the acute MI, which was pretty stable when we looked at the model development, so the model's performance was similar when you developed it and you looked at it internally, but now we can look at the external validation. So how well did the model do when it was applied to different data sets with different outcome phenotypes or different target populations. So here we've got a row is the model that was trained in CCAE applied to CCAE, model was trained in IQVIA applied to CCAE, trained in JMDC applied to CCAE, and so on. So all of these are the models that applied, trained in different data sets but applied to CCAE. And then each cell here corresponds to a different phenotype for the outcome and target population combination applied to some outcome and phenotype and target population definition. So the diagonals in this kind of rectangle here, it means that you were just, well, this was the same database and the same definitions for the outcome and target populations. This was internal validation. But anything off the diagonal meant that you were applying the model to its either a different phenotype outcome or a different target population or both. And then in the other data sets, you were actually doing external validation and testing. Anything off the diagonal means you're actually seeing how it changed if you affected the phenotype for the outcome or the target population. And what do we see? Well, we see actually the performance is pretty consistent. Other than the model trained in Medicare applied to CCAE, most of these are similar colors. So actually in this situation for acute MI, we're seeing stability of the phenotype for the outcome and the target population. The only difference really was if it depends on the database. So Medicare, generally, the models don't do so well when they're trained or applied to Medicare data. And we see that here, that the Medicare data consistently, all the models perform poorly on the Medicare compared to the rest. So we see we do have stability for the acute MI, and the biggest difference is the database. So in conclusion, the database choice makes the biggest impact. So we're seeing stability across target populations and outcomes for some prediction problems, but they're still sensitive to the database. And this tells us that for certain tasks like the acute MI, we could probably develop models and use them, transport them to different settings and potentially a clinical setting. But for other tasks, because it's very sensitive, we should actually be doing a lot of work to make sure that our phenotypes are correct, or we're confident in our phenotypes, or maybe not do the prediction because it may not be suitable. So you just saw all the work the OHDSI community have been doing for methods research in COVID-19. Have a 10-minute break and come back and see the clinical impact that we've been making for the COVID-19 pandemic research.
Hello everyone, I'm Seng Chan You in Korea. I'm currently working as a research professor in the Department of Preventive Medicine, Yonsei University College of Medicine. I'm a board certified internist and currently working as a data scientist in the university. Today, I'm going to talk about review about the prior COVID-19 studies, especially related with estimation and predictions. So in 2019, OHDSI planned to have a study-a-thon in a beautiful campus of Oxford. But then, as you know, the pandemic happened. So we changed our plan and we initiated the collaborative research against COVID-19 during the planned study-a-thon. So from 26th to 29th March 2020, OHDSI has had a COVID-19 international study-a-thon. At that point, no one expected to that we can use the real COVID-19 patient data for this study-a-thon, but Korean government decided to join this international study. So in the regular briefing on March 27th, the Korean CDC announced the launch of global research collaboration project on COVID-19 by using Korean nationwide COVID-19 patient data. In this study-a-thon, OHDSI conducted a lot of studies, but I'd like to highlight 3 questions. First, is proposed combination of anti-malaria drug and antibiotics safe enough to use in patients with COVID-19 without convincing evidence for efficacy for COVID-19? Second, is use of ACE inhibitor or ARB is associated with outcome of COVID-19? And third question was, can we predict vulnerable persons who will have poor prognosis due to COVID-19? For the first, start with first question. At that point, again, 2020 March, a French doctor proposed that malaria pills can cure COVID-19. And actually, at this moment, many patients with COVID-19 were treated with this malaria drug, hydroxychloroquine. But we do not know the safety profile of hydroxychloroquine. So we conducted an international study to evaluate the risk of hydroxychloroquine alone or in combination of azithromycin in patients with rheumatoid arthritis. So we plan to investigate the risk of outcomes, including serious adverse events such as cardiovascular disease, arrhythmia, or liver failure. In this study, we found that long-term use of hydroxychloroquine in patients with rheumatoid arthritis can increase the risk of cardiovascular mortality. Moreover, short-term use of hydroxychloroquine and azithromycin increase the risk of severe mortality when used short, like 30 days. So it was shocking. This finding was announced by Harlan Kramos, the collaborator of OHDSI, and he said that benefit is not clear, but risk seems clear. And European Medicine Agency warned the use of these drugs in COVID-19 patients, again, because of the risk of serious side effects we found. The second question was the use of ACE inhibitor and ARB was associated with outcome of COVID-19. So because SARS-CoV-2 virus uses ACE2 receptor to enter the human cells, and we thought that ACE inhibitor and ARB ARB can alter the prognosis of COVID-19. So we conducted an international open science cohort analysis to investigate the association between RAS inhibitors and susceptibility to COVID-19. This study, led by Daniel Morales, found that use of RAS inhibitor was not associated with COVID-19 diagnosis or hospital admissions related outcomes by using 3 large databases from Spain and United States. And this study was highlighted by EMA in Sept Guide on Methodological Standards in Pharmacoepidemiology. They said that this study supported the reproducibility by publishing the study protocol ahead of time, and it used the start to finish executable code and facilitated the sharing and exploration of complete result set with an interactive web application. And this finding was confirmed by randomized clinical trials later. The third question was, can we predict vulnerable persons who will have poor prognosis due to COVID-19? At the moment, again, at the March 2020, many countries, including Italy, faced the crisis of medical supplies. So we need kind of the prognostic prediction tools to allocate our medical resources or prioritize who needs more care or who needs more protection from COVID-19 infection. So by using historical data with flu patients, we developed a cover model based on machine learning. And when we transferred this model into COVID-19 patients, we found the performance to predict hospitalization or intensive care service or fatality was quite good in large databases from Korea, Spain, and United States. So this cover model was further validated by one of the largest hospitals in Spain, and the Spanish Catalan regional government actually used this model to enrich their classification of high-risk COVID-19 patients during outbreak summer 2020. During the 3-day study-a-thon, we had more than 300 participants from 30 countries, and we reviewed more than 10,000 publications. We drafted 9 protocols and released 13 study packages. It was really a tremendous opportunity for researchers to do something for COVID-19, the active pandemic. And I want to say that open science promotes the more accurate verification of scientific results by combining the tools of science information technology. Scientific inquiry and discovery can be sped up for the benefit of society. And I believe that OHDSI shows the benefit of open science, including the great innovation potential, or it can promote citizens' trust in science, which is really important during this pandemic season. Thank you for your time. Okay, I'm gonna turn this over to Talita Duarte-Salles.
Hi everyone, my name is Talita Duarte-Salles. I'm an epidemiologist at IDIA Jordi in Barcelona, Spain, and it's a pleasure for me today to present the impact of the CHARYBDIS project on the COVID-19 pandemic, doing a brief overview of the main results of the project in the last 18 months. So it's also an honor for me to be given the floor today to summarize the work from CHARYBDIS, given the number of people that have been involved in the project in different ways. So here's a list of the 130 co-authors who have collaborated in the manuscripts that have been or are on their way of being published so far. So as you can see, this is the result of a tremendous community effort, and I'm honored to be able to give this presentation today in name of the CHARYBDIS team. And before I continue, I just want to take the opportunity to thank everyone who has contributed to this project. We couldn't have done it without this amazing team, so thank you. So I know many of you are probably already familiar with CHARYBDIS, but for those who don't know what it is, I will take a minute to give a brief overview on the project's objectives. I won't have time to go into much detail today, but if you want to know more about the project, last year I had the opportunity to present CHARYBDIS in the OHDSI Symposium. So if you want to know more about CHARYBDIS, you can go to this link and listen to my presentation there. For those of you not familiar with CHARYBDIS, this is a project that started during the COVID-19 study-a-thon that happened in March 2020, when we actually knew very little about the disease. CHARYBDIS stands for Characterizing Health-Associated Risks and Your Baseline Disease in SARS-CoV-2. The overall objectives of the projects were to describe the baseline demographics, the clinical characteristics, treatments, symptoms, and the outcomes of interest among individuals with COVID-19 overall, but also stratified by sex, age, and specific comorbidities such as obesity, cancer, or autoimmune disease, for example. And also to describe the characteristics and outcomes of influenza patients between 2017 and 2018 compared to the COVID-19 population. The food study protocol is available in the OHDSI GitHub website, and you can find the link here. And now jumping straight into the results, here you can see a snapshot of the databases that participated in CHARYBDIS up to January 2021. So overall, we had 13 databases from the US, 9 databases from Europe, representing 6 different countries, and 3 databases from Asia, including data from South Korea and China. Altogether, we were able to obtain results from a total of 17.2 million people tested for COVID-19, more than 4.5 million cases of diagnosed or tested positive for COVID-19, and more than 890,000 patients that were hospitalized with COVID-19. So here is a summary of the main outputs of CHARYBDIS. There were more than 2,000 papers reviewed by the literature review team. There were 107 definitions that were created for COVID-19 and comorbidities cohorts by the Phenotypes team, which are publicly available in Atlas. There were more than 100,000 characteristics described by each of the COVID-19 cohorts per strata and per database. So you can imagine the amount of results that were generated and are publicly available at data.ohdsi.org. There were also 16 scientific manuscripts written. From those, there were 6 that have been already published in peer-reviewed journals. 5 that are publicly available as preprints and that have been submitted to a journal, and other 5 that are still in preparation are already submitted to a scientific journal. I won't have time to show the results of all of these studies today, but if you're interested, you can find a complete list of publications at the OHDSI COVID-19 updates website. Now I would like to highlight some of the main findings today from CHARYBDIS. I think that this is one of the most important studies that was published by Ed Byrne and team in Nature Communications last year. This was the biggest study on characterization of hospitalized patients with COVID-19 compared to patients with influenza. And this was published in a very important time when there were some world leaders such as Bolsonaro in Brazil or Trump in the US saying that COVID-19 was just like a little cold. And in this study, we actually showed that patients hospitalized with COVID-19 were healthier, younger, with less history of medicine use, and with much worse outcomes than influenza patients. We were also able to show that COVID-19 patients had worse outcomes among the pediatric population or patients with cancer or autoimmune diseases when we compare them with influenza patients. We also showed that COVID-19 patients with a history of cancer or autoimmune disease had worse COVID-19 outcomes than persons without history of these comorbidities. Another important study led by Albert Prats was this one on the use of drugs during hospitalization of COVID-19 patients, but I won't go into the details for this one since Albert is going to tell you all about this after this presentation. This study led by Martina Recalde and Elena Roel showed that obesity was more common in COVID-19 patients than in influenza patients. In this study, we also showed that persons living with obesity were more frequently hospitalized, they needed intensive services and had higher fatality rates than non-obese persons. This study was very important at that time since we showed the role of this other pandemic, the obesity, in worse COVID-19 outcomes. We had a chance to present this work in a WHO meeting on obesity and COVID-19. And the study was used by WHO to raise awareness on the importance of improving obesity prevention strategies around the world. And here's the full list of already publicly available preprints that were focused in population subgroups such as pregnant women, tested populations, HIV positive persons, the use of interventions among COVID-19 cases, or the general paper with more details on the CHARYBDIS project. You can find the link to these publications in the OHDSI website. And finally, here are some of the final remarks and lessons learned from CHARYBDIS. I think that it was very clear from the beginning of the pandemic that to solve a global problem like this pandemic, we needed a global solution. And here's where I think that a community like OHDSI had a unique and important role, since we were able to create in only a few months the biggest COVID-19 data network in the world. With this network and the community, we were able to provide reliable and timely evidence on the natural history of this new virus that greatly helped informing decision making. We were able to show the similarities and differences in the characteristics of COVID-19 using very different types of databases from many different populations and population subgroups of interest. But unfortunately, this is how our map of the OHDSI COVID-19 data network looks like at the moment. So it's very clear that there's an important part of the map missing here, and that we need to put more effort into engaging with new data partners from the Global South to join the community if you want to be even more ready for future pandemics. So please, if you have access to data in the Global South, please join the journey, go to ohdsi.org, contact us, and we see how we can help you getting started. Also, this is quite obvious, but in such a big project and also in the virtual world, we saw how important leadership, collaboration, commitment, and patience were for the success of the project. We had 11 study leads for 16 manuscripts, 130 co-authors working in different tasks such as literature review, phenotype definitions, data analysis, etc. And 25 data partners willing to run and rerun packages, as well as to provide us with feedback on the findings observed in their data. We also needed to have hundreds of calls, some with special guests and some definitely more fun than others, but all of them necessary for the success of the project. We also saw how important it is in the OHDSI model of open science with full transparency, making the study protocol, the analytical codes, the phenotype definitions, the results, and the manuscripts publicly available as soon as possible. We are now still working to get some papers published, but we were able to share the preprints already last year when these findings were extremely needed for a better understanding of the natural history of COVID-19. And to finish, I believe that CHARYBDIS has a tremendous added value for future studies and pandemics, since we are now more ready than we were to perform this type of international network studies. We established a long list of new collaborations and had many new data partners who joined the CHARYBDIS journey. Also, kudos to Anthony Sena, who developed the characterization package, which is, I think, the basis for any future clinical characterization study in the community, and has already been used in other studies such as Pioneer or HERA. Thanks to him, we were able to generate a huge amount of results that we haven't been able to analyze yet. So if you're interested, please go to data.ohdsi.org and have a look at all the produced results. Thank you very much for your attention, and to everyone who helped creating this CHARYBDIS monster, especially to Kristin Kostka and Albert Prats for co-leading the project. Thank you. And now let me hand it over to Albert Prats-Uribe.
Hi, I am Albert Prats-Uribe. I am a DPhil student at Oxford, and I'm going to talk to you about drug utilization trends in COVID-19. So these are my co-authors, and a paper came out of this work that you can find here. It's published in the BMJ, and I'm going to talk you a little bit about it, about some parts, but here about some drugs, and here you can find more drugs and much more material. So why do we need a drug utilization study? At the start of the pandemic, we saw how several medicines were being repurposed on the basis solely on in vitro activity. And then a lot of not so good observational data came, and also there was a lot of tweets and press conferences by very influential people saying things like this.
Hydroxychloroquine? I'm taking it, hydroxychloroquine.
When?
Right now, yeah. A couple of weeks ago, I started taking it. Because I think it's good. I've heard a lot of good stories.
So there's a need to know what was happening in real clinical practices with these drugs. To do so, we used several data from all over the world, South Korea, China, Spain, and the USA. And what we looked at was the active drug use on hospitalized patients. So let's see what we found out. Hydroxychloroquine use. As you can see, in the x-axis you have the month of year 2020, and in the y-axis you have the percentage of hospitalized patients that were given this drug, hydroxychloroquine in this case. So in February, there was the first report that remdesivir and chloroquine could inhibit coronavirus in vitro. But if we move forward to March, there were even more reports about in vitro activity of hydroxychloroquine. There was more social media and press conferences, and there was also not so good observational research saying that it could be effective, and as you see, the use went up. And we also have some social media declarations like this.
Bem, estou tomando aqui a terceira dose da hidroxicloroquina.
But then we moved to April, the first reports saying that hydroxychloroquine may not be as safe, especially combined with azithromycin. As you see, the use starts to go down. In May, it even goes down further with reports saying that it doesn't work. And finally, in June, a trial came out saying that it didn't work, and the use of hydroxychloroquine went to almost zero and continued zero throughout the year. So if we move now to the use of dexamethasone, a drug that actually works, as you can see at the start of the pandemic, the use was relatively low, less than 25% in most sites. But in June, the recovery trial showed that it was useful reducing mortality in patients, hospitalized patients with severe respiratory disease. And as you see, the use of dexamethasone goes up and stays up for the whole year, and even more so if we count in the use of other corticosteroids. To conclude, at the start of the pandemic, there was high heterogeneity on the drug use, and there was these first months were mostly driven by in vitro results and poor quality research. But once we produce good quality research, the trends quickly changed, and the drug use was according to the best research available. I want to thank you all co-authors and all contributors, and thank you for your attention. And here you can find the paper and much more information. And now I'm going to turn it over to my colleague, Xintong Li.
Hello everyone, I'm Xintong Li, a PhD student from University of Oxford. It's an honor for me to present the work on the characterizing the background incidence rates of adverse events of special interest for the COVID-19 vaccine. I believe most of you have heard a lot about vaccine safety these days. We raise the safety concerns on the media a lot. And when talking about safety of the vaccination, there's one term I would like to introduce, which is adverse events of special interest. So that's a set of events that could coincidentally happen in the general population and also be seen to some kind of related to one of the COVID-19 vaccine. So the background rate is the rate in the population that's without vaccination, and the observed rate is the rate among the population who are vaccinated. So the background rates are generated from either literatures, real-world databases, or some other data sources, while observed rates can be acquired from either self-reported spontaneous data or routinely collected healthcare data. So we get these two rates, we're going to compare them, and we could see if any rate and observed data is unexpected, then we may consider that there are some safety concerns with such outcomes. So that's what we call a background rate comparison method in vaccine safety study. This method has been used a lot in the previous vaccine safety studies and also in the monitoring COVID-19 vaccine. Here's an example I borrowed from the UK regulator, where they comparing the rates from spontaneous report to a background rates on Bell's palsy. However, since the COVID-19 vaccine is such a new vaccine and on the market for such a short time, we don't actually have too much information about the adverse events of special interest and also their background rates as well. So in the study, we aim to estimate the background incidence rates of the 15 pre-specified adverse events of special interest among a general population between 2017 to 2019. So this is the retrospective cohort study, and we included 13 databases. And of course, all of them are mapped to all of the common data model. A brief look about the databases included. We have 5 claims data and 8 electronic health record data, covering area from America, UK, Europe, Japan, and Australia as well. The study design. You may have heard about the instance rate sensitivity analysis from Anna in the previous session. And for here, we are using a background population that entered the cohort from January 1st of this year. And we require 1 year observation in the databases for the participants to be eligible to contribute for follow-up times. We include 15 events that's ranging from cardiovascular events, immune-related neurological events, and other events as well. So when we estimate the incidence rates, we also stratify the results by age, male and female, and also by databases. Furthermore, we put incidence rates together from all the different databases using random effect model, and we estimate the confidence interval. Also, we classify the event rates based on their frequency. So here's the results. We have included over 100 million people, and they contribute to more than 200 million years of follow-up. We found there are patient-level heterogeneity and also population-level heterogeneity. I will explain those two words later with the detail of the results. So first look at the pooled incidence rates, which is by age and sex, and classified on the frequency, which is from the Council of International Organization of Medical Science. So on the left-hand side, we could see the frequency classification, and it's ranging from very rare, which is green, to the very common, which is yellow, which is red. So on the plot here, we could see the events we including here, they're classified from very rare to common. None of them are very common. So on the row we have age and S group, and on the columns we have age outcomes and also male and female. Let's look into more details. Here I'm using one outcome, which is acute myocardial infarction as example. So we see that for the very younger age, the events incidence rates are classified into very rare, while for the elder age, they are classified for non-common or common for the oldest group. And also we could see with the age increases, the events frequency increased as well. Also, we could see that even for a single age group, that the male and female incidence rates are classified into different groups as well. So that's what we call age and sex heterogeneity here. And that's the incidence rates are hugely affected by age and also by male or female. So this also informed us that when classification is done with the incidence rate, a single class is never enough. Then let's look at the incidence rates by each of the databases. So on the x-axis, we have age and also male and female. On the y-axis, we have the incidence rates. Each the points here on the plot represent estimation from one databases, while the circle represents female and the triangle is for male. So we could see for this set of outcomes, we could see there's a chance for increasing with age for encephalomyelitis and also for Guillain-Barré syndromes. Well, and for other diseases, there's not like too obvious chance. Here's another set of the outcomes. Most of them are cardiovascular related. So we can see there is a trend that increasing age are leading to increasing incidence rates for all of the 5 outcomes. Also, for example, we're looking at here at stroke, we can see that the triangle are higher than the circle in most of the same age group. So this telling us that the incidence rates in male are higher than female. Here's another set of the outcomes. Again, we saw age trend with appendix, Bell's palsy, but not too obvious with other sort of diseases. So let's look down into only one outcome. Here I'm using the IC as an example. So I highlighted only one age group and also one group which is female. So all the points are estimation from one participant databases. So we could see that even for this age 6 stratified outcomes, the incidence rates for this specific group could ranging from like below 1 to over 100 per 100,000 person years. So that's what we call heterogeneity between the databases, that there are heterogeneity in the incidence rates which is beyond age and sex. So in general, we could see there's our age effects as very strong in the background incidence rates that we must address for it whenever we use the rates. And also we could see there are databases different which is beyond age and sex. So whenever we're using the methods I introduced in the previous slides, that comparing the background rates versus the expected rates versus the observed rates, we should consider using Bayesian databases consideration whenever possible. And also, since we saw there's a like huge heterogeneity with the background rates, and when using the comparison methods, we may caution that they might suffer from high type 1 error. So the study has been published on the BMJ in the middle of this year, and since then it has been cited by other scientific articles as well. And for the articles like the discussion about Bell's palsy, thrombosis, and some of sarcopenias and other events as well, that all covered in our adverse events of special interest list. Furthermore, our results have been used for the government's guidelines as well. Here's an example from Australia, the guidelines on myocarditis, that they use our background rates to support the point that events can happen in the general population without vaccination as well. The background incidence rate has also been used by the European regulator, the EMA, on COVID-19 vaccine safety. So we can see here they comparing the background rates and the exact rates for the vaccines and the safety concern for myocarditis. And also the background rate has been further used by the EMA in their ongoing projects and also some further projects as well. So we have an online app available for the study results that you can click on the link, or you can go and look at it to see all the details of our results. And also our sources, sources are available here on GitHub. So all the data partners are welcome to run analysis to see how the background incidence rates look like in your population, and share results with us if you want it. So here's the end of my presentation. I'd like to thank you everyone. Thank you all the collaborators, and I'm happy to take any questions. Thank you. Now let's turn it over to Marc Suchard about his presentation.
Hi, my name is Marc Suchard. I'm a professor of biostatistics at UCLA. Today I'm going to talk about Project SCYLLA, which aims to evaluate the comparative effectiveness and safety of repurposed drugs for COVID-19. During the first year of the pandemic, clinicians tried more than 3,000 different drugs to treat COVID-19. Researchers also performed greater than 2,800 different drug studies of variable quality to evaluate these drugs. The observational studies amongst these were limited by a small number of drugs studied under any one design in very restricted populations, limited focus on safety, mostly on comparative effectiveness, and many of the designs were user versus non-user, which can be confounded by indication. Project SCYLLA wanted to ask, is it possible to deliver reliable evidence for repurposed drugs from real-world evidence in real time? In order to do this, we chose a new user active comparator cohort design. Using this design, we evaluated all drugs against each other within different drug classes. In particular, we looked at 650 different treatment combinations amongst antibiotics, antidiabetics, and antithrombotics as just a few examples. Not only looking at effectiveness outcomes for COVID, we also included a large number of safety outcomes and executed this study across a global network of databases. In this case, 9 different data sources. In order to provide reliable evidence in a comparative cohort design, we wanted first to systematically quantify study diagnostics to ensure covariate balance across the cohorts. If they are balanced, this leads to an unbiased effect estimate. Clinical equipoise that tells us about how generalizable our results are across the population. And of course, statistical power, or how sensitive we are to find differences. I find it very hard to visualize how covariate balance works. So what I've done for us is I've created this plot on the right that takes a continuous outcome of, in this case, outcome probability on the y-axis versus a continuized more or less treatment 1 versus treatment 2 on the x-axis to see how covariate balance works. In this cartoon example, there really are 2 populations of patients. In blue, we have the patients who have a covariate of being sicker. In red, we have patients who are healthier. And as you can see from the gray dashed line, if we were to just look at the marginal effect and not balance or adjust for differences in covariate, we get the incorrect estimate, which shows that more treatment 2 is related to a higher probability of the outcome. Whereas if we do assure balance or adjust and stratify, we get the correct estimate in the dashed line with exactly the opposite ratio. Most of the 20,000 comparisons that we looked at in Project SCYLLA are likely to be unreliable. Over on the left side, I have a couple different Venn diagrams, which is showing the intersection for each of the studies in different databases between those that passed the 3 different diagnostics of balance, equipoise, and power. Across our databases, somewhere between 0% to about 5% are actually likely to be reliable. In general, the proportion of studies which showed sufficient power or equipoise was much greater than those that showed balance. And this really does, in terms of equipoise, suggest that patients were, in a sense, randomly assigned to different treatments. But even in that sort of different random assignment, there were significant differences in those patients, as shown by the balance. And this is an important cautionary tale that we should keep in mind when we try to interpret all of those 2,800 prior drug studies that are there. Most of them are likely to be unreliable. Nonetheless, among the comparisons that did pass our diagnostics, there were a couple of results that are important from a clinical perspective. One question researchers are interested in asking is anticoagulation, using heparin, for example, too risky in patients with COVID-19? And our results show that they're not too risky. As a matter of fact, in comparing heparin versus aspirin, we actually see a lower risk of many important cardiovascular safety events, such as acute MI, stroke, and persons experiencing chest pain or angina. Additionally, a final question we might want to look at is prednisone a suitable alternative to dexamethasone in terms of treatment for COVID? And there seems to be a definitive answer that prednisone is a suitable alternative with a slightly lower hazard ratio as compared to dexamethasone across a number of COVID outcomes. Now, no work is ever done in a vacuum, and I need to thank my entire SCYLLA and Data Partners team for this work, and also the Bill and Melinda Gates Foundation for their support. Thank you. And now I'd like to turn it over to George Hripcsak.
Hi, my name is George Hripcsak from Columbia University. I'm going to be talking about vaccine effectiveness. I'm going to be talking about work that I've done with Anna Ostropolets, also from Columbia University. COVID-19 vaccines are highly effective, and we have good evidence that we're highly effective, but there's still more to be learned on things like dosing and timing among the vaccine options, how their effectiveness endures over time, the effect of variants, boosters, mixing different vaccines, and so on. We can see this, so what we carried out is more or less a measurement study. Is it feasible for OHDSI to do vaccine effectiveness research? We started with two questions. To what extent vaccines are effective when following the protocol, that is after full vaccination? And what is the time course of effectiveness after the first and second doses? To do this, we knew that we had to address several challenges. First, exposure capture, that is exposure to the vaccine, to ensure that we have a comprehensive vaccination record so that when we say someone wasn't vaccinated, we're sure we got that right. Then if we're going to compare two cohorts, in the unvaccinated cohort, what do we use as an index date? If you're vaccinated, we know the date of vaccination, but if you're not vaccinated, then what's your date of non-vaccination in effect? Do we have sufficient sample size, exposure, and follow-up time? How to define our cohort outcomes, and then how to address normal bias that you would see, for example, index event misclassification. First, on exposure capture, we started with data from Columbia University Irving Medical Center, because the medical center has an automated connection to the city and state public health departments, their vaccine registry. So we get real-time feeds on who was vaccinated. That gives us all within-state vaccinations for our population. So we're pretty sure when people weren't vaccinated. We started out with a simple cohort design, our target group being vaccinated, our comparator group being unvaccinated. The index event of full, if you're vaccinated, it's the date of vaccination. We compare that to someone who wasn't vaccinated, either by matching on a visit that they had for other reasons, or for just an arbitrary date in their record that matched the vaccination date. We defined several outcomes, including COVID diagnosis or positive tests or hospitalization, and we use OHDSI's traditional Cox proportional hazard model with a propensity score matching. We ran the study and we did actually quite well on our diagnostics. Shown here, first of all, we tested all three vaccines, Pfizer, Moderna, and Janssen. Shown in the two rows, first is comparing a vaccinated person to an arbitrary date in the unvaccinated person's record. And the bottom row being comparing the vaccine to a medical visit in the unvaccinated person. The left half are the preference score graphs that say how good is the overlap between the vaccinated and unvaccinated groups. We like to see good overlap. In the date group, you see that there's actually excellent overlap in all three vaccines. In the bottom, we see when we compare visits, it's a little bit easier to distinguish the vaccinated from the unvaccinated. I think that's because for COVID-19, people are getting their vaccine not during a medical visit, but during when it's convenient for them or when it's available to them, and getting it in potentially non-medical sites. So there's a little bit of difference, yet the overlap is still sufficient for us to carry out our research. On the right, we see covariate balance, and in all six figures, every one of our tens of thousands of covariates were under the industry standard of 0.1. So we have sufficient equipoise and we achieve covariate balance. Now that we pass diagnostics, we can look at the results. Shown in yellow are the trial results, and shown in blue are our results. The triangle shows our results for infection or diagnosis, and the circle is for hospitalization. And what we see is that the vaccines are highly effective, and we mimic that. You see that our hazard ratios are all below 0.5. They're not quite as low as the trials. And, you know, we could think about it and try to explain that perhaps because some of our data from more recently, and there's the Delta variant. So we duplicate the trials showing that they're highly effective, although we didn't quite match the trials in effectiveness. And this is where many groups would stop, publish the paper, and say that we've succeeded in demonstrating that the observational research confirms the randomized trials. And furthermore, just to further confirm before I go on to show the Kaplan-Meier curves, and these are reasonable. So these also confirm that we did a good job. Then we started asking questions to say, well, is this really reliable? The vaccine's highly effective when fully vaccinated, but what happens just after the first dose? So one study we did is looking to see if we just look every time after the first dose, so including those first 2 weeks where you don't expect much effectiveness. The yellow in this graph is the fully vaccinated group, and the blue is the potentially not fully vaccinated. And we can see a difference that the blue, although there shows some effectiveness, is not as effective as the yellow, which confirms kind of what we expected. So this is a confirmation of reasonable results. Now we show the Kaplan-Meier curves. Now what we expect here is that in the first week before antibodies are formed, we shouldn't be seeing any effectiveness. If we look at the upper left red square, that the two curves are pretty much overlapping before they diverge, and that's what we're looking for here. But the other three figures, they start to diverge earlier than we would have expected. It's not a big effect, but it is something suspicious. It made us suspicious. So then we started to think about what this may be doing. And one effect may be because one of our groups, if we try to make things equal and compare fully vaccinated people to the same cohort, that is fully vaccinated people in the first week, well, what's the problem with that? Well, if you're fully vaccinated, it means for at least for two of the vaccines, you got to a second dose, which means you didn't die of COVID in the first week. That creates a mortal time bias. Therefore, we used our other cohort, which was just having at least one dose, regardless of whether you made it to a second dose. And when, in fact, we right-censored it at the second dose to really pull out what happens when you have only one dose. And as you can see from the figures, although it's not perfect, it does bring the two lines closer together in that first week. That is, it improves our outcome, but it's still not solved. So then we said, well, let's look specifically at the first week and see how bad off we are. And if we look here, all of the estimates are showing effectiveness in that first week. In fact, that one in the red rectangle, the Pfizer one for hospitalization, shows the confidence interval is pretty far from 1. So we're showing way too much effectiveness in the first week from what we expected. So then we dove more deeply. One thing we noted in the structured data is that we, in our definition of hospitalization, it looked for COVID diagnosis within 2 weeks before or after it. Well, if we look in the first week of hospitalization and they had a COVID diagnosis 2 weeks before that, it means they had COVID before they were even vaccinated. It's clearly not what we're looking for. So that definition needed to be changed. So we fixed it. Unfortunately, that moves it in the wrong direction for the first week, but is still a problem that we needed to fix. Second, we found a number of false positives indicating that at least in the first week after vaccination, a lot of those positive COVID codes were either long COVID, that is the COVID that happened previously, and this is just the patient coming back with continued symptoms, or in fact, it was a pre-op test and that was listed as kind of rule out COVID, but it was coded as a COVID diagnosis. So we had a number of false positives. We fixed that, but again, that made our problem worse. Nevertheless, it had to be fixed. So then we did a deep dive chart review. So the first thing we did, shown there as number one, is we confirmed the earlier two problems that we fixed. In fact, we found that 43% of positive COVID diagnoses on week 1 after the first dose of Pfizer were in fact false positive in the sense that they had a negative COVID test the same day. I know that there are COVID negative examples, but they're rare and shouldn't be 43%. A big problem came out here where patients, when they're vaccinated and they get symptoms, assume that the symptoms are due to the vaccination. So we found that people were only showing up in the first week if either they had severe COVID symptoms or they came in for another medical condition and got a COVID test just as a screening and then turned out to have COVID. So we're losing a lot of our COVID patients because they're not coming in because they think that it's the vaccination. And the last thing that we found is a delay that, in fact, when we had what's recorded as a COVID diagnosis in week 1 is actually the week before vaccination. Week 2 is actually from week 1 and so on. So what we did is we did the best we could to address all of these things. We couldn't address that middle one, number 2, where patients are not showing up. So that's a continual bias. But we will run that test on the fully vaccinated. We find now that we, in fact, perfectly overlap the study results. So we see the confidence intervals. The yellow is the clinical trial, and the blue is our observational research. And now there's much better coherence between them. So in summary, let me just reiterate that we need observational data to answer ongoing COVID vaccine questions, variants, durability, mixing, etc. The study design is complicated, but we believe feasible. I won't go through them, but those are the kinds of things we went through. In order to solve them, we needed diagnostics, we needed to iterate on the design, and we needed a deep review. So this is what OHDSI is good at and needs to continue doing. Our results match clinical trials very well now, although we're still investigating the week 1 bias and is there anything we can do about patients not showing up because they suspect it's not COVID. But the bottom line is the OHDSI community must come together now with its data, its methods, and its researchers to make important contributions on vaccine effectiveness. We need more sample size, more diversity, and more expertise. I suggest that we move forward on CREAS, one of the 12 titans on comparative effectiveness research on immunization used for SARS-CoV-2. Thank you for listening. Please now enjoy a quick energy break and come back at the top of the hour for our COVID-19 OHDSI panel.